The DOACs, direct oral anticoagulants, are now replacing vitamin K antagonists for the main indications for anticoagulation, atrial fibrillation and venous thromboembolism. Immediately after their launch, there was a huge degree of concern. What if patients develop a bleed? How should we optimally manage them? And this concern was driven by the fact that there wasn't any agent that can specifically reverse the effects of such a new oral anticoagulant, where the other one, vitamin K antagonist, already had their antidote in place. So what I discussed today is how we should manage in 2018 our patients with bleeding disorder and what with bleeding on anticoagulants and what we can expect in the future. The first part of my presentation was really about patients experiencing a major bleeding, and the real question is what proportion of patients that have a major bleeding, in which cases is the bleeding that severe that you would really need an antidote to reverse the anticoagulant effect. And if you break it down, all the patients from the trials with major bleeding complications, we find that it's about 40 to 50% of patients. Is the glass full? Is the glass half empty? Well, that's basically up to you, but it's not the full proportion of patients with major bleeding, about half of those patients. The second part, I moved into the evidence that we actually have about the effects of such antidotes. We all know that these antidotes are able to correct laboratory parameters and reverse the effects of the anticoagulant. But the question we should be asking is, does that improve the outcome of the bleeding in our individual patients? And if you take a closer look, well, actually there's some cynicism there, because there has been one randomized study in patients on vitamin K antagonist where they did or did not receive such an antidote. And what we saw was immediate, swift normalization of the laboratory parameter, but essentially the outcome of the bleeding was identical. There was absolutely no difference. So that really forces us to focus on the clinical outcome of the bleeding, and maybe we should not forget, but downplay the importance of the role of laboratory reversal. Then in the next part I went through the current options and the options that will be available in the next future for patients who bleed on direct oral anticoagulants. For the oldest DOAC, the Bigatran, there is now an antibody which works perfectly fine. For the factor Xa inhibitors, 3 of those, it's not sure who the winner yet is, although there are 3 compounds now in development, and there's one of those who actually has a significant head start in their clinical program. If everything looks fine, well, they should be registered within a year or so. But there is also some degree of concern, and that's actually the latter part of my presentation. We know that if we treat patients with antidotes, we may be increasing their risks of subsequent thrombosis after the bleed. Those compounds we're infusing, they may activate our coagulation system. So in this latter part, I really try to raise awareness for the fact that we should also be focusing on those thromboembolic complications after the bleed. And it seems to be that this risk is about 5 to 10% in your first month after having a bleed. And that automatically brings up the next question. When should you resume your anticoagulation for those patients who have had a bleed and who are now recovering or have recovered from the bleed? And basically that's really the field where we don't know anything. It's really eminence-based medicine instead of evidence-based medicine. I try to give some clues, some highlights as to what choices you could make, but in the end, we're really lacking evidence in that field, and I think that's one of the newer challenges we should be focusing on in the forthcoming future. One thing that automatically happens when a patient who is on anticoagulants has a bleed is that we stop their anticoagulation. And of course they had an indication for anticoagulation to start with. So if you develop a thrombotic episode after your bleeding, is that the original thrombotic disease coming up, basically now anticoagulated because we stopped it after the bleed, or is it the antidote itself? And actually those two are quite hard to disentangle, and probably stopping the anticoagulation is the mainstay. I think, especially now that we have different compounds, anticoagulants and different reversal agents, I think we can now start to disentangle whether or not these antidotes themselves have prothrombotic effects. And I think the answer is that some of them may have prothrombotic effects. Treatment, well, fairly simple actually, because if you develop a prothrombotic condition, you need anticoagulants. The hairy part about that is, of course, that you need to install those anticoagulants in a patient who has just had a recent bleed, hoping that he will not re-bleed again when you really have to restart those anticoagulants. At one point, if I may, I would like to raise, we always call it benign hematology, and I understand it as being the opposite of a malignant disease. But essentially we need to appreciate that benign hematology is just not a right word. If you're speaking about bleeding and anticoagulation, 1 in 10 patients dies of that bleed. And if we focus in on patients with intracranial hemorrhage, 1 in 2 patients dies. And well, the survivors, more or less half of those remain chronically debilitated. So yeah, thrombosis hemostasis, that is my field, that is my passion. I am obviously looking for those sessions at BSH, and I think we have a couple of nice ones here today on the schedule here. What the BSH could offer is really serve its own British doctors. What British doctors really need is they need their colleagues, their field experts, the ones they trust, laying out what they should or should not do in their clinic tomorrow. So I think it's probably more about the educational aspects of our colleagues than about the cutting edge new science, which probably goes to international meetings anyway.